Good day, everybody. My name is Luis Raez. I'm the Medical Director of Memorial Cancer Institute here in Miami, Florida. It's a pleasure to accept this invitation from eCancer. We're going to review 4 of the most important presentations of ASCO 2025 in the area of lung cancer. We're going to start with a review of CheckMate A16. If you were not there, Dr. Patrick Forde presented final survival analysis data of this study. If you remember, A16 is a very important study because it was the first time that we had a randomized study for neoadjuvant immunotherapy with chemo for early stage non-small cell lung cancer. Remember, he was the first one to present years ago showing a benefit to do chemo immuno versus chemo alone for neoadjuvant therapy, 3 cycles of chemotherapy with nivolumab for patients with early stage non-small cell lung cancer that are going to go for surgery. That was some years ago, but the importance is that we didn't have the survival at that time. You know, that regime was approved by the FDA based on the disease-free survival. Now we have finally survival data. So the survival data that they presented show a hazard ratio of 0.72, meaning that there is a 28% benefit if we add immunotherapy to this neoadjuvant intervention to the chemotherapy. To make it easy to visualize, what we can tell you is at 5 years, at 5 years of follow-up, there is 10% more patients alive having immunotherapy with nivolumab instead of having chemotherapy alone. So that's an easy way to see the benefit of this intervention. 10% more people alive having immunotherapy before chemo instead of only chemo alone. So there is a benefit. And remember, we're talking about only neoadjuvant. This study doesn't have any adjuvant portion. You know, we only give the 3 cycles of chemo immuno, surgery, that's it. During the same time that we were waiting for this data to come, as you know, we have 3 other studies, one with durvalumab, Aegean, one with nivolumab, also similar to this one, CheckMate 77T, and one with pembrolizumab, the 771, the Kino 671, that show that if we do neoadjuvant chemoimmuno and we do adjuvant immuno after, there is a benefit in survival. Yeah. So that's what this study is different from these 3, the other 3. The other 3 studies, we call them perioperative. Perioperative means that we give the immunotherapy before and after the surgery. So we have the 3 perioperative studies. Again, CheckMate 77T, Kino 671, and Aegean, the one with durvalumab. And you know, everybody knows that also there is a study called NeoTorch in China with another PD-1 that we don't have here. So all of these studies, perioperative, show benefit given the immunotherapy before and after, and that's also FDA approval. This study is interesting because, as I said again, the benefit is only when we are doing the neoadjuvant portion. There is no adjuvant. So the question, of course, is the most popular question is, do we need adjuvant? No. So if there is a benefit survival, only given 3 cycles of chemoimmuno, why we're going to put the patient for 1 year extra? And remember, after surgery, we don't know which patients need adjuvant. We give to everybody, but some patients may not need it because they may be cured. You know, a lot of stage 1B or 2 patients may not need it because they may be cured already. Okay, so that's the benefit of the neoadjuvant intervention. Everybody needs immunotherapy and chemo. When you do adjuvant, not everybody needs. Okay, so one way that we can settle this is Dr. Patrick Forde, as he did before, this is not the first time that they show that there is a survival benefit for the people that has complete pathological response. In other words, if you get 3 cycles of chemoimmuno and you get complete pathological response, you may not need adjuvant because the patients in this study, practically all of them at 5 years are alive if they achieve a complete pathological response. If they didn't achieve a complete pathological response, of course, there is a group of patients that are not here. The other group that benefit tremendously is the patients that have a DNA clearance. ctDNA in the blood is not standard of care, but it's going to be standard of care soon because we are start to monitoring ctDNA in many indications, in lung cancer and other cancers. If you have a DNA clearance, your survival is much better than if you don't have a DNA clearance. So that's why, in conclusion, this study is very important because it opens the possibility that maybe if you get neoadjuvant chemoimmuno, you may not need adjuvant therapy if you have a complete pathological response, okay? Not all of us are 100% in agreement with that because, the scientific way to do that, to deny people adjuvant therapy, will be to do MRD and find an MRD test that is 100% accurate. So we can tell the patient after surgery, your MRD is negative, you don't need anything. We don't have a test of that sensitivity yet. We have a very good test that we're testing now for many industry partners, but we don't have the test yet. That's why it's still a controversial topic. But it's up to you. If your patient gets complete pathological response, maybe you don't want to give adjuvant immunotherapy. Because, as I said, both of them are approved. The other abstract that was very interesting is the one that we are the combination of Lurbinectedin and atezolizumab as a first-line maintenance for patients with small cell lung cancer extensive disease. This was presented by Dr. Luis Raez. If you remember, the standard of care in extensive disease, small cell lung cancer, is we give 4 cycles of chemotherapy, carboplatin etoposide, followed by maintenance atezo. That's standard of care. In this study, people were randomized in the maintenance part. So everybody gets the chemo. And in the maintenance part, instead to have atezo alone, 1,200 milligrams every 3 weeks as a standard of care until progression, they get the atezo, the same dose, 1,200 milligrams every 3 weeks, plus lurbinectedin, 3.2. We use lurbinectedin every 3 weeks. And to make the story short, probably that the results were positive. There was a hazard ratio of 0.73, meaning a 27% benefit if we add lurbinectedin to atezo. Why we need to do this? Because remember, even being standard of care atezo maintenance, pretty much we lose half of the patients in the first year. That's why in this presentation, the maintenance with atezo alone is only 44% in 1 year. So 44% of the patients are alive in 1 year if you are in a standard of care maintenance atezo. That's an improvement with before when there was no maintenance. But it's not enough. If you do the lurbi plus atezo, the number of patients is 56%. So there is a 12% increase in number of patients that are alive if you do maintenance with both agents instead of do maintenance with one agent. And of course, the overall response rate, complete response, partial response, everything is in favor of the combination. And of course, also, there is an increase in toxicities because we're using now 2 agents instead of 1. So there is more toxicity, but the patients live longer. The extra toxicity is nausea, fatigue. So in other words, the extra toxicity is a toxicity that can be managed. I'm not discouraging toxicity, but it's a toxicity that can be managed because these are side effects that we can manage, like a nausea, all of these things. The other presentation that was very important, this was a very, very good ASCO for a small cell, was Tarlatamab. Tarlatamab was approved last year in May for use in small cell lung cancer for people that has failed frontline therapy. So, but we didn't have the phase 3 study, and I think this was some sort of conditional approval. Everybody was waiting for the phase 3. And the phase 3 study is the DeLLphi-304 that was presented by Dr. Rudin in ASCO. So basically, remember, the Tarlatamab is a bispecific T-cell engager, and the other arm of the antibody is the target is DLL3. DLL3 we're researching for a while now in lung cancer, and we were unable to get a drug approved. There were other drugs before Tarlatamab, but they were not bispecific antibodies, so this is a successful story. So basically, patients that have failed first-line therapy with platinum-based therapy and now standard of care is anti-PD-L1, They were randomized for chemotherapy versus tarlatamab. Remember, chemotherapy for 20 years is the second-line standard of care. We use a lot of topotecan. Some people don't like it due to the toxicity and prefer to use irinotecan off-label. Now we had Lurbinectedin available for the last 2 years. So, but anyway, and in Asia they have ambrubicin. No, these are the options. But you know, the second line and third line for small cell is very short outcomes, but not very good outcomes. So in this study, DeLLphi, the patients were randomized for tarlatamab versus chemotherapy, as I said, in second line. And basically, the study met his primary endpoint. The overall survival increased 5 months. The median overall survival increased 5 months from 8.3, that is usually what we get, and that was actually even better than what we get with the standard chemo, to 13.6. So the hazard ratio was 0.6, that is like a 40% improvement in survival, 40% improvement in survival. And again, to make it an easy words for the audience, in 1 year, we have only 37% of people alive with chemo. While we used tarlatamab, it was 53%. So there is a tremendous 16% improvement in survival numbers if we are using tarlatamab compared with standard chemo. And that's why now, I guess, tarlatamab is moving to second line. We knew that from last year, but last year we only have data from phase 2 study, and not everybody agreed to put tarlatamab second line. They prefer to keep it third line because tarlatamab, remember, the first 2 infusions of tarlatamab needs to be done in the hospital because there is a chance of ICANS and there is a chance of CRS, cytokine release syndrome. So that's why the first 2 infusions we do in the hospital. By the time that the patients are getting infusion number 3, we bring these patients outpatient to the cancer center because they don't get really these ICANS or this cytokine release syndrome. It's the first 2 infusions. So that's why a lot of people last year were not happy using tarlatamab yet, but now that you see this tremendous benefit in survival, I think there should not be doubt that we should be using tarlatamab as a second line. The logistics, again, are challenging. There are publications already how to use tarlatamab outpatient, but in general, most of us prefer to use infuse the first 2 infusions in inpatient, and then we move to the outpatient setting. Finally, the last abstract that we're going to discuss today is the NeoADAURA. You know, the NeoADAURA is very interesting because it's osimertinib with chemotherapy for EFR patients before surgery. No, everybody's familiar with the use of osimertinib after surgery with ADAURA. But this NeoADAURA was expected because, as I mentioned in the first part of the presentation, immunotherapy now is standard of care as a neoadjuvant. If you want to use immunotherapy with chemo, it's standard of care. And everybody had a high expectation. How about the TKIs? You know, can we use the TKIs at front? And that's why this NeoADAURA was very important. It was presented by Dr. Jamie Cha from Sloan Kettering. So basically, this was a 3-arm study. They gave osimertinib alone, neoadjuvant, everything neoadjuvant. They gave osimertinib with chemo, or they gave the chemo alone. No, the 3 arms, and basically what she presented, if you remember, is the major pathologic response is very high. It's 26% osimertinib plus chemo, 25% osimertinib alone, and 2% chemo. Yeah, the reason why in lung cancer chemotherapy is not standard of care alone as neoadjuvant is because exactly this. Complete pathological response or major pathological response are very low. So that's why we don't use it. We just start to use now chemotherapy thanks to immuno. Yeah? So chemo alone is not standard of care neoadjuvant, it's chemo immuno, and maybe with this data that we just had with NeoADAURA, you can debate that, hey, but maybe we don't need the chemo because the osimertinib alone causes the same major pathological response. We don't have the event-free survival data because they need to mature. The curves are separating. That's what she showed in ASCO, but the data needs to be mature. And of course, the overall survival also needs mature. So we'll be seeing that in another meeting. It's obvious that if we use chemo with OSI, there are more adverse events than if we use OSI alone. but we're used to, because everybody has been using FLAURA2 for metastatic disease, so we know when we mix OC with chemo, there are adverse events. Okay, but they are very manageable too. So that's a very interesting presentation. So maybe we are very close to move TKIs, at least osimertinib, to the front line, at least for stage 2 or 3 non-small cell lung cancer. Anyway, this is all the time that we have. Thank you very much for your attention. Thanks for Cancer for this invitation. Will be until the next time.